I'm Dr. Ken Landau. Thanks for watching. Let's talk about Lipitor, more commonly known as Atorvastatin. That's a statin drug used to reduce your cholesterol, specifically your bad cholesterol, your LDL cholesterol. And supposedly you take the drug and then you don't have a heart attack, you don't have a stroke. In the world, there are going to be about 17 million deaths this year from cardiovascular disease. Here in the United States, about 400,000. About 1 or 2% going to be less than age 45. On the other hand, in India, just that one country, there will be about 3 million deaths, and about 45% are going to be in people less than age 45. Now, what are the risk factors for heart disease? The standard risk factors are the older you get, the greater your risk. You have a family history, you're at risk. You have high blood pressure, a poor diet, you have too much salt in your diet, you don't exercise, you smoke cigarettes, drink too much alcohol, and if your bad cholesterol is up and your good cholesterol is down, you seem to be at risk. When you're born, your cholesterol averages, your total cholesterol averages about 30, and then it slowly increases. We know when your bad cholesterol exceeds 60, then you start developing some degree of atherosclerosis plaque. However, plaque doesn't necessarily equate to heart disease. Well, what we would like to do is we would like to treat people to reduce their risk. So those people who have the greatest level of LDL seem to be at greatest risk, but also you can have a totally normal cholesterol and be at high risk because you're a smoker, because you're not active, because you have diabetes, because you have hypertension. So we have to look at all of the risk factors. It doesn't do much good just to treat one. However, the more of those risk factors you have, treating any one of them is going to reduce your risk a little bit, at least. So people at highest risk need the most treatment. People at lowest risk need the least treatment. Lipitor is a drug that was first synthesized in 1985 by a company known as Warner Lambert, subsequently taken over by Pfizer. When the drug was manufactured, there wasn't much interest in it. And as a matter of fact, it was thought to be an also-ran drug, because there were several others to do the same thing on the market at that time. And it almost didn't even get any testing. But the chemist gave it to some of the people who worked in the laboratory, and as a matter of fact, their cholesterol went down even further than they anticipated. They presented the evidence to the Food and Drug Administration, and actually in 1996, it was granted marketing approval. It became the 5th statin on the market, and as a matter of fact, became the best seller on the market because it seemed to work the best. Now, how do we determine whether you should take a statin? We decide that you've had some kind of a coronary event. You've had a heart attack, you might have had a stroke, you might have peripheral vascular disease, you might have angina. We want to prevent it from reoccurring. That's what we call secondary prevention. You've already had some kind of event and we want to prevent it from happening again, so you take a statin. Primary prevention, you're at risk, maybe because you have diabetes, maybe you smoke cigarettes, maybe it's just you have a high level of bad cholesterol, low level of good cholesterol, maybe a family history. So you're at high risk, but you haven't had any kind of coronary vascular event. You're still now eligible to take the medicine. So we've expanded from the high-risk group, high risk meaning you've had an event, to a lower risk group. They're not going to get quite as much benefit. And now people have taken it even a step further. They say even if you have normal cholesterol, your LDL is relatively normal, but you're at high risk from other causes, either genetics or high blood pressure, diabetes, or smoking cigarettes, then you ought to take the drug too. That's at least what some people say. Supposedly, if you take a statin drug like Lipitor, you are going to reduce the likelihood that you're going to have a heart attack or a stroke or angina, or you're going to have the need for a stent or coronary surgery. How do the drugs work? All of the statins work the same way. What they do is they prevent the liver cell from manufacturing a chemical called mevalonate. Now, mevalonate is a required precursor to manufacture cholesterol. You don't manufacture the mevalonate, and you're not going to get cholesterol. So that's how it works. It works in the liver. The liver is a principal site of synthesis of cholesterol. Not only does it reduce the production of the cholesterol, but it causes some surface receptors to form on the liver cell that go and gobble up all of the LDL that's floating around in the bloodstream. Well, if you have a low dose of a statin, it will work, supposedly, by making the plaque that you have more stable. If you take a higher dose, it will supposedly act by causing inflammation in the plaque to go down. So there are two mechanisms of action here. It's not just the cholesterol-reducing effect. It's cholesterol-reducing and anti-inflammatory. That's why you take aspirin. It's anti-inflammatory. Well, how much Lipitor should you take? The dose is anywhere between 10 milligrams and 80 milligrams, but the Food and Drug Administration said 80 milligrams causes too much muscle damage and potential liver damage, so don't take that. Just take the 10, the 20, or the 40 milligram dose. Well, how do you decide which one to take? If you're at low risk, you take a low dose. If you're at high risk, you take the 40 milligram dose. Pretty much that simple. It's rapidly absorbed. It reaches the maximum blood level after about 1 to 2 hours. Actually, since your liver manufactures most of the cholesterol overnight, it might be even better if you take the pill in the evening rather than in the morning. The pill has a half-life of about 14 hours inside the bloodstream, inside the body. Seems to be metabolized in the liver and goes out in the bile. What's the appropriate level of cholesterol? Well, actually, people don't pay too much attention to the total cholesterol anymore. They say that desirable is less than 200. It's high if it's more than 240. And it's borderline if it's in between. But more importantly, people are paying attention to the bad cholesterol, so-called LDL. The optimal level is less than 100. It's non-optimal if it's 100 to 130. It's borderline high between 130 and 160. It's high if it's between 160 and 190, and you need therapy when it gets to be over 190. Now, as far as the HDL is concerned, that's the good cholesterol. We don't really understand that one at all. Some people say that the higher the level, the better. But we know it's the function of the HDL. So you can have a lot of it, but it might not be doing what it's supposed to do. Actually, they've been saying that the higher your level is, the less likely you are to have a heart attack. But we know in a village in Italy, the levels are phenomenally low, 10 to 30 instead of 50 or above, and they're very unlikely to have heart disease. So we have to say LDL, we know that too much of it probably isn't good. The HDL, we're not so sure. Now, the question is, how should we treat people and who should get the statins? Well, the answer is, if you've already had an event, you need treatment. That's what they say. So if you've had a heart attack or a stroke, or if you've had chest pain, or if you had bypass surgery, or if your bad cholesterol is more than 190, you need therapy, or if you're between ages 40 and 75 and you have diabetes, you need therapy, or if you're between 40 and 75 and you have an estimated 10-year risk of having one of those events, that's more than 7.5%, then you need some therapy. Well, some people say, instead of 7.5%, how about between 5 and 7.5%? We'll throw that in. And then over in Europe, they used to say your risk had to be over 20%. Now they say, we'll stick with the over 10%. Well, how do we calculate this risk? You go to the web, just like your doctor's going to do, and you put the numbers in, and it will tell you what your risk is. It's only for people between the ages of 20 and 59. All you need to know is your age, your sex, your race. You have to know your good cholesterol, your bad cholesterol. You have to know your systolic blood pressure. And then you have to input some information. Are you a smoker? Are you diabetic? Are you taking a statin? Do you take aspirin? However, the problem is that the risk calculator that's used overestimates your risk by anywhere between 75 and 150%. That was known by the American College of Cardiology, American Heart Association. When they published this information, it was told to them by Dr. Stephen Nesson, who is the director of the cardiovascular unit at Cleveland Clinic. He is the go-to guy for heart disease in the country. And he told them, but they didn't care, They just put out the guidelines. Now, the question is, what level should we treat to? So we know when we start treatment, but how low should we push the cholesterol? Used to be said that, well, less than 100 on the bad cholesterol, then it was less than 70 on the bad cholesterol. Now it doesn't matter. You just go and take the cholesterol-reducing medicine, and you take the intensity of the cholesterol-reducing medicine, and that's all you're interested in. You don't treat to a specific number. On the other hand, the National Lipid Association, European Society of Cardiology, they still say, unlike the American Heart Association, American College of Cardiology, they say that we should treat to less than 100 on the LDL, maybe less than 80, maybe less than 70. It all depends on whose guidelines you want to follow. According to the American Heart Association, American College of Cardiology, if you are at high risk, you need a high-intensity statin. That means 40 milligrams of Lipitor or Atorvastatin. That means your bad cholesterol is more than 190, or you've previously had some kind of cardiovascular event. Now, you need a moderate intensity drug, 10 to 20 milligrams of Lipitor, if you happen to be at moderate risk. Moderate risk means you haven't had a coronary event yet, you haven't had a stroke, you don't have chest pain, you're between 40 and 75 years of age, but you have diabetes. And on calculation, your 10-year risk is more than 7.5%. On the other hand, you need a low-intensity drug, maybe 10 milligrams of Lipitor, or maybe you take some simvastatin, or maybe you take some Pravachol. If you happen to be at low risk, meaning age 40 to 75, you don't have diabetes, your bad cholesterol 70 to 189, and your risk, well, people argue about what the risk is, whether it has to be over 7.5% or over 5% or over 10%. But those people who are at low risk need low-intensity steroid, or low-intensity statin, rather. So if you're pregnant, can you take the drug? Probably not a good idea. Probably shouldn't take it if you're breastfeeding either. If you're taking a birth control pill, it will increase the amount of the hormone that's in your system. If you have liver disease and it's active, then probably not a good idea to take these kind of medicines. So we test to see what your liver function is before we start. It used to be said that we should monitor it as we go along. Now the Food and Drug Administration says, yeah, you don't even have to do that anymore. It's said that we have to be a little bit careful about anything that would suggest a muscle disorder. And we know that if you have kidney damage, or you're likely to have kidney damage, maybe you've had major trauma, maybe you have acute infection, maybe your blood pressure is very low, maybe you have some kind of metabolic or endocrine problem, then we probably should stop the medicine until you get better, because that would predispose to breakdown of muscle tissue, which is a major deal when you're taking these drugs. Fortunately, not all that common. Well, if you happen to be taking a statin, you have to be careful of some other drugs. You shouldn't take it with clarithromycin. You shouldn't take it with colchicine. Got to be careful with erythromycin, the antibiotic. You can't even have grapefruit juice with Lipitor. You can with some of the other statins, not with Lipitor. And you have to be a little careful if you're taking diltiazem or verapamil. Those are calcium blockers. Side effects are the usual kind of side effects you get with any kind of medicine: nausea, vomiting, abdominal pain. Sometimes you get some arthralgias, or you can have worsening of the pain in your extremities. That is a significant issue. Well, this muscle pain can occur in as many as 1 in 10 individuals. You can get over it most of the time by decreasing the dose or changing to a different statin, or even stopping for a while and then seeing if you can re-challenge the patient with the same kind of a drug. It's usually well tolerated, actually, but the question is, when you say you have muscle problems, what do you mean by muscle problems? Is it muscle spasm, muscle weakness, muscle ache? Do you have some muscle fatigue? Or are you actually breaking down muscle tissue? Well, they all carry different connotations. But certainly if you have rhabdomyolysis, where you break down the cells, you've got a major issue. You better stop the drug right away. So if your urine turns different color, or if your skin turns a different color, your eyes turn different color, you better stop the drug right away and get over to your doctor. And that occurs mostly, but not always, in people who have uncontrolled hypothyroidism, or people who are over age 65, people who have kidney disease, or people who are taking the statins with clarithromycin or maybe certain of the other drugs, even like niacin. Well, those people, when they develop the muscle weakness, they have to go see the doctor. Are there any other side effects? Sure. Recently, it was studied, at least the drug precipitant was studied, a relative, and it was found to increase the incidence of breast cancer. We don't know exactly what that means. That's relatively new information. It might turn out to be something important, might not. The FDA added some warnings in 2012, and they said they found an association with taking the statins with diabetes. The statins will raise your sugar a little bit. Well, some people say, who's at greatest risk? Older people, postmenopausal people. It seems to occur most commonly, the sugar going up in Asians and in Caucasians rather than blacks and Hispanics. Well, if the sugar goes up a little bit, is that such a big deal? Some people say, well, people who have high sugar should be taking the statin anyway, so you're already there. Other people say, no, that's a big deal. Well, I think that probably is overblown. Now, there's another issue that might not be overblown. It's a question about memory loss. Cholesterol is very important as far as the brain cells are concerned. And in 2012, it was reported that people became forgetful and confused and had some fuzzy thinking. And the question is it age-related or is it drug-related? Lots of lawsuits over the drug right now having to do with either the muscle damage or the nerve damage, the memory loss, or maybe diabetes. The drug brought in a phenomenal amount of money to the manufacturer. It was selling at $11 billion a year prior to the time it went off patent in 2011. So $11 billion every year for this drug. In 2012, however, now off patent, it brought in $4 billion. In 2015, it only brought in $3 billion. And amazingly, the drug companies tell you about how they have to put all this money in R&D. Well, in the time during which it was patented, those 12 or 14, 15 years that it was under patent, it brought in $125 billion just for this single pill. Or in other words, it brought in a quarter of all of the money that Pfizer was bringing in. That's pretty doggone impressive for a drug. Well, how much does a drug cost? Well, if you go and you buy the Lipitor brand name, it's going to cost you somewhere between $500 and $600 a month. On the other hand, you can go get the generic Atorvastatin over at Costco for cash, $15 a month. Most drugstores you can buy at $20 to $40 a month. On the other hand, for whatever reason, if you go to Walgreens or if you go to CVS Target, it's going to cost you cash $150 a month. But if you go get a coupon from GoodRx that's free, you could get that same drug for anywhere between $8 and $14 a month. So something to consider. Now, most importantly, in the United Kingdom, they're just starting to sell a relative of Atorvastatin. This is called simvastatin. They're selling the low dose over the counter. Here in the United States, the drug companies say, yeah, we want to do that too, because that's going to boost the sales. Food and Drug says, we're not sure the people are sophisticated enough to understand the drugs and whether they should take them and how much they should take. And as a matter of fact, we in medicine aren't even so sophisticated that we understand. So let's go through and see how important reducing your cholesterol, reducing your bad cholesterol happens to be. The journal, British Journal of Clinical Pharmacology, in July of 2016, evaluated all of the studies, and what they found is shocking. They found that they increased your life expectancy, your survival, anywhere between 0.5% and about 3 1/3%. Average, a little bit less than 2%. So the drugs benefited you, absolute number, by a little less than 2%. And if you took it as a primary prevention, the numbers I just quoted to you were for secondary prevention, so people already had a heart attack. So they're going to benefit by increased survival less than 2%. On the other hand, primary prevention, the study showed either no benefit or up to 0.9%. Average study, 0.5% increase in absolute survival. What's the difference between the numbers that you're quoted? You see all the time it's 30%, 40%, 50% reduction. And I'm telling you that's not the case, because the numbers that they're quoting are what we call relative numbers, and I'm giving you absolute numbers. So let's do a simple experiment. We'll take 200 people. This group is going to get a placebo. This group is going to get an active drug. This group, after a period of time, has 2 events. This group, taking the drug after a period of time, has 1 event. The drug company looks at that and says, look, we went from 2 to 1. That's a 50% reduction. That's the number that they're quoting to you. I'm telling you that 2% minus 1%, that's a 1% reduction, 1% benefit. That's why it's so important to know the statistics. Now, if we look at the average life prolongation, how much longer are you going to live if you happen to take a statin? And you've already had a heart attack, or you've had a stroke, or you've had some other kind of cardiovascular disease. The studies suggest that you will indeed live longer by about 4 to 6 days. And if we're taking it for primary prevention, you haven't even had the heart attack yet, you might live longer, and it might be about 3 days. And those are studies where it hasn't been compared to taking an aspirin, going on a Mediterranean diet, going and getting some exercise. But I'll tell you what, if you want to live longer, and you're a cigarette smoker, and you quit smoking at age 30, you will live 10 years longer than you would if you continued to smoke. And if you discontinue the cigarettes at age 50, you're going to live 6 years longer. And if you discontinue the cigarettes when you're 60, you're still going to get 3 years of benefit. That's a hell of a lot better than 4 to 6 days, I would say. Well, you go to the doctor more when you get older. And when you get older, the doctors put you on more pills. And the thought is that old people, people over age 65, need to be taking these lipid-reducing medicines like Atorvastatin and Lipitor, because those people are at the greatest risk. But evidence suggests that the risk actually of high cholesterol goes down as you get older. And the cholesterol may be not even a significant risk factor. And as a matter of fact, some of the studies show that people who have low levels of cholesterol, if they're older, have higher levels of death, greater all-cause mortality. So it might not be such a great idea to reduce the cholesterol in senior citizens. And Lilly, major drug company, presented a drug known as evacetrapib. That's a phenomenal cholesterol-reducing medicine. It dropped the bad cholesterol quite significantly, boosted the good cholesterol quite significantly. And when they presented to the American College of Cardiology in April of 2016, they reported absolutely no benefit as far as heart disease was concerned, no benefit as far as stroke was concerned, and no coronary vascular disease benefit. And actually, again in the British Medical Journal, in 2016, a study was presented where they looked at the average cholesterol of a group of random participants, and what they found was the total cholesterol didn't have any really significant association with the degree of atherosclerosis. And as a matter of fact, atherosclerosis is probably an inflammatory disease. It's probably not a cholesterol-related disease at all. And everyone seems to agree nowadays that what happens is that something causes endothelial damage. Endothelial cells are those cells that line the inside of the arteries. Something damages them. They are dysfunctional. And then we have an influx of inflammatory cells, white blood cells, macrophages, T lymphocytes, and they go and they damage some of the underlying tissue that responds with proliferation of the vascular smooth muscle cells. We get all the inflammatory products, the cytokines, and then we have some fibroblastic proliferation, and that's what the plaque is. And why do you get the plaque? Why do you get the inflammation? Maybe because you've got some dental problem, maybe because you're a cigarette smoker, maybe because you have some stress, you're fat, you have high level of iron in your system, or lipid peroxidation, or maybe it's just the total amount of substance in your diet, something in your diet. Maybe it's just stress. We don't know. But there is accumulating evidence that it's not really as much of a cholesterol problem as was thought once upon a time. There's another problem. The problem is medicalization. We give too many pills to people. So you take an aspirin. You take some hormone replacement therapy if you're a woman. You take some vitamin D. You take a multivitamin. You take some omega-3. Maybe you have diabetes. Now you're taking a couple medicines for diabetes, and now you have high blood pressure, so you're taking 2, 3, or 4 medicines for high blood pressure. Now we're going to add a statin. When really all of these problems may well have to do with diet, because when we look at primitive tribes that don't have any westernization, they don't have the kind of problems that we do. They don't have the coronary vascular disease. They don't have the plaque. They don't have the obesity. They don't have any of the problems with high blood pressure that comes along with our kind of diet. So maybe what we really ought to do is consider the Mediterranean diet, consider some of the other changes that we can make simply in our lives rather than taking 20 pills a day. And as a matter of fact, now they have a shot for cholesterol that you take every once in a while. 2 shots, actually. One's called Repatha, the other's called Praluent. You can get the low-density lipoprotein, the bad lipoprotein, you can get it down to as low as 25, 30, 35. Does it prevent you from dying of heart disease? Well, not really. Anyway, so when your doctor tells you that you need to reduce your cholesterol, what the doctor's really telling you is you need to change your lifestyle. You need to get off the cigarettes, get off the excess alcohol, get off the sofa, go for a walk, go get some exercise, bring your weight down. Change your diet. Now, people say, I've changed my diet and it doesn't work. That's because you didn't change your diet the right way. We tend to have a lot of carbohydrate in our diet. Well, the new evidence suggests that a diet that's high in fat, the appropriate kind of fat, and high in protein and high in the complex carbohydrates, low in salt, that's going to be a heck of a lot better for you than the traditional American diet, traditional even American Heart Association diet. Are you going to benefit from taking a statin? Well, ask your doctor when he tells you or she tells you that you should go on a statin like Lipitor. Ask them to see the evidence and don't look at the number, the big number, the relative risk reduction. Look at the absolute risk reduction. And I think you'll find what I just told you is true. The benefits of these drugs, highly over-promoted. Anyway, thanks for watching. I'm Dr. Ken Landau.